this, I had two presentations that we gave on the utilization of advanced imaging in acute stroke care. One of them, we looked at multiple platforms of multiple AI platforms, and one of the other study, Validate study, was more specific to the Viz AI platform. That study, we have got into a bit more detail, has actually been submitted for publication, so a little more granular data on that study, in which we were comparing the facilities that we work with that use an AI platform, in this case Viz AI, to those that don't have one. So in order to kind of best understand both of these studies, I think it helps to explain a little bit about where the data is coming from. So the studies both come out of the Telecare by Telespecialist database, which is acute stroke consults seen across the country in 30 plus states now. The studies are different individual states based on the population we're including at that time. But these patients are seen by the same group of neurologists in all different practice settings, whether they're a comprehensive stroke center that we're working in or an acute stroke ready. It's variable, it's real life telestroke services, and this data is captured through the Telecare database. So when we looked at the Validate study and we were looking at the Viz AI compared to no AI platform, we found that there was a very large difference in the arrival of the patient to the hospital facility to the notification of the neurointerventionalist that there was an LVO to go after. And that impact was really quite profound. The non-AI facilities took 90 minutes, whereas the AI platform facilities took 50 minutes. So a 40-minute reduction with the use of the Viz AI platform. Now, we all know when you think about the different ways people practice, some people are going to say, but I'm a comprehensive center, so that's not going to affect me. I'm not the small hospital out there. So we did actually break that data down further into thrombectomy capable centers where the procedures are happening where the patient is, and those that are transferring their patients to another facility. And when we looked at that, we still found not quite as high, but still a big impact in the thrombectomy capable centers. They had a 78-minute for the non-AI platforms compared to a 44-minute using the Viz AI platform. So a 34-minute reduction instead of 40, but still very significant. And in those facilities that were not using an AI platform, there was a 79-minute arrival to NIR notification in the no AI group and a 64-minute in the AI group. So again, a 33-minute reduction that we saw there. So the data remained very consistent. We took it a step further into trying to really get that neurologist contact to the NIR contact time as well, because there is variability in upfront processes that the AI software would have nothing to do with. If a hospital delayed calling a neurologist, then what does that have to do with the software? So the limitation in the overall data with that is that we do get pre-notification. So the EMS notifies the hospital calls us, the neurologist gets on screen, and will sometimes be sitting there with unaccounted for time. And then there's also triage patients where if it's not noticed right away and it takes a half hour, that's adding to that arrival to NIR notification time. So we did kind of tease out further to exclude those pre-alert patients where the neurologist would be sitting on screen, one analysis, and then another analysis in which we looked at just those pre-alert patients. And the really interesting thing that I did not expect to find was how big of a difference there was in that pre-alert patient group. The difference from the neurologist to notifying the NIR doctor was 58 minutes. So the difference actually got bigger in the pre-alert, so that there seems to be some sort of synergistic effect to having the AI platform and the pre-notification. You could argue that those facilities have more resources, and that may be why we saw such a large impact, as those facilities might just have the ability to have a better team on the ground, a better workflow, because there are other resources that they have there. Certainly a possibility that we consider with that. But even with that excluded patient data set that we saw, we still saw a very profound impact. With that time, we were trying to narrow down to the teleneurologist with the patient to calling NIR was still a 28-minute difference in the overall group. And then for the thrombectomy centers, it was a 23-minute difference, and the non-thrombectomy centers, 35-minute difference. So no matter how we splice it up and look for it, we are still seeing a very big impact of the platform on the faster contact to neurointerventionalist time. And then looking with the other study, the advanced imaging software improving times to thrombectomy, in that case, we wanted to make sure that this was a universal effect. This wasn't something specific to the Viz AI platform, but was it more just something we see because you have an AI platform? So we looked and included any AI platforms that were being utilized by the facilities and compared them to the non. So it is a larger study, which had a little over 25,000 patients in it that we gathered over a 6-month time period. And in that study, we still saw, again, a very profound impact of that 90-minute average, it was 89 here, but roughly 90 minutes for the non-AI group compared to 55 minutes in the AI group. So still a big improvement there. And we also noticed that there was some differences in the LVO detection rates, as well as the patients being accepted for neurointervention. So we saw more LVOs identified in the AI platforms, but less taken. So leads you to believe that there is a potential of making better decisions before transfer. So hopefully, we're still teasing out a little more of this data to see if we can prove that to be true, that it's reducing futile transfers of patients that weren't going to be taken. And we did an analysis of which vessel was occluded and compared that between AI and non-AI platforms. And the interesting thing is there was no difference in the vessel occluded, the proportion of which vessel occluded was found in each group, or in the acceptance rate. So it's not that the platform allows you to find an M2 that you were not otherwise finding, and therefore they're taking a different set of patients or declining a different set of patients. The acceptance, the overall vessel just didn't seem to impact that either way, which surprised me. I was suspecting we were finding more distal things with the AI platform model than the no AI platform, but that was not the case. But we did still see that 34-minute improvement in this study. So despite the platform that you use, both of these studies together really show that having that AI platform, whatever environment you're practicing in, at least with a telestroke model, is very effective in helping reduce that time to getting these patients to procedure of over a half hour. And we all know how many brain cells you can lose in a half hour of needing a thrombectomy. So it's very, very significant. What we are able to get by working with those platforms is we have on either cell phone or website the ability to get the CTAs and perfusions in a very rapid recon fashion, immediately available to the neurologist, where they also have LVO detection tools, the AI part of it, in which it's telling you suspected LVO and alerting you to look at that case quicker. The communication platform aspect is also significant for us because when you look at the non-AI groups of both of these studies, that means an image is taken, it's gone to get reconned, it ends up in a PAC system. A radiologist looks at it. We can get into the PAC system and look at it too, but often the recons are not done as timely because the rapid NVIS softwares do it very quickly. And then when we're calling an interventionalist, they can't see it. Whereas with the rapid and the Viz platforms, the interventionalist often has that image in front of them. They're looking at it, we're looking at it, the radiologist is looking at it. Everybody has it basically in their hand to discuss and determine what to do with that patient. So I think in my mind, these platforms are not all about the AI, but a lot of these other features that come with them that really coordinates care and makes it so while I'm not physically present, maybe even in the state with that patient, we're still all able to look at the same thing at the same time in such a fast way.